Hello and welcome all to our 208th weekly webinar series today. It's great to see all of you online on a Sunday morning. Thanks to the internet, online connectivity, and the dime a dozen apps, staying safe indoors does not mean missing out on meeting interesting people and imbibing positivities from their work and life. Over the past 4 years and 9 months, we have been able to put together online programs to keep our AABN community not just engaged, but also meet a range of inspiring people who can help shape their ideas and thoughts. AABN has always strived hard to provide up-to-date information and developments that are of interest to you and have wider economic implications for the country and the world. AABN has been engaging you with the objective of helping you hit the refresh button on emerging trends on a range of topics. This Sunday too, you would be delighted to know that we have two illustrious speakers. Despite bold claims, tuberculosis remains one of the most pressing global health challenges, disproportionately affecting marginalized communities. Despite being preventable and treatable, TB continues to take a significant toll on humanity. According to the World Health Organization's Global Tuberculosis Report 2024, an estimated 10.8 million people developed active TB in 2023, resulting in approximately 1.25 million deaths worldwide. While medical advancements in TB treatment and diagnosis play a crucial role, they alone cannot eliminate TB. What we need is the power of community engagement to ensure TB prevention, timely diagnosis, treatment adherence, and public awareness. The health system forgets that TB is not a medical condition alone. It exists and is fought in a social context and within families and communities. This makes active community participation a fundamental part of an effective TB response. On this webinar, we'll be joined by Dr. M. Muniyandi and Dr. N. Karikalan to discuss under the title World Tuberculosis Day 2025, Driving Social Behavior Change for Collective Action Against TB. Friends, put your hands together for our guests and let me have the privilege of introducing them to you. Dr. M. Muniyandi is associated with ICMR, National Institute for Research in Tuberculosis, in various capacities for the last 24 years. Currently holding the position of Scientist D, Head of the Department of Health Economics and Coordinator for Regional Resource Center for Health Technology Assessment in India, in ICMR, National Institute for Research in Tuberculosis, Chennai. He is a leading researcher in the field of socioeconomics, health economics related to TB control in India, involved in diverse socio-economic, behavioral, and epidemiological research and intervention projects in the context of improving population health. He is a leading researcher in the disease control program with special emphasis on health economics and health accounting, working on projects that address key themes, bridging health and social issues with the help of microeconometric modeling. He was invited as a speaker on health economics on TB at several international and national gatherings. He has undergone several training programs in Harvard School of Public Health, Johns Hopkins, Bloomberg School of Public Health, University of Michigan School of Public Health, Brown University, USA. He has more than 135 scientific publications, both in national and international journals. A very warm welcome to you, sir. Dr. Karikalan is a public health researcher with 2 decades of diverse expertise and experience in India. He works as a scientist and heads the Department of Social and Behavioral Research of ICMR, National Institute for Research in Tuberculosis. His research focuses on understanding the social, behavioral, and economic determinants and risk factors for tuberculosis. He also coordinates the socio-behavioral research network for TB in India. His research is aimed at addressing challenges faced by people with TB, including alcohol use, stigma, mental health, comorbidities, catastrophic expenditure, and poor health-seeking behaviors. Dr. Karikalan has played an instrumental role in initiating Wings of Support, a support group initiative for providing psychosocial support for persons with TB and the family caregivers. He also actively contributes to the Nikshay Mitra initiative of Pradhan Mantri TB Mukt Bharat Abhiyan, to mobilize nutritional support for TB patients. He is committed to the goal of TB Mukti Bharat and as envisioned by the Honorable Prime Minister of India. A very warm welcome to you, sir. Before we wind up, let me once again extend a very warm welcome to all and reiterate that our AABN doors are always open to those who might want to strengthen our work with the suggestions. I also wish to place on record a deep commitment to work tirelessly as a team to carry forward our goals in a constructive, gratifying way. Thank you. Let us start this session with Dr. Muniyandi first.
Sir, thank you so much for this forum, inviting us and to share my little knowledge in this forum. Thank you, sir. Thank you so much. Thanks for this nice introduction. So, there's a tuberculosis infectious disease. This is not the new one. It's a very old diseases. But in 1993, there is a control program is there in this country to control tuberculosis. The well-structured program was there. When this program was reviewed in 1993, then they identified so many lacunae. When the new economic policy was introduced, globalization all coming to the picture in 1993, then the WHO announced it's a global emergency. It's not the India's problem. It's a global problem. Then demand came from the globally. So which country have a more population like China and in India, they have to control TB. Otherwise, where the developed countries, they have already controlled the TB. Because of these countries where more population and high burden of TB, it may come back to the other developed countries. Then the WHO announced, can you hear me, sir?
Yes, sir. Yes, sir. Yes, sir.
Okay. Then WHO announced in 1993, declared TB as a global emergency. The countries needs to be controlled. Otherwise, it's going to be a problem in the developed countries. Then India, at that time, they have a program. Then they reviewed. Then they identified so many problems like drugs is not available or patients are not coming for the treatment. If patient comes, there is a delay in diagnosis and the not enough supply of drugs. All these problems they identified. Then what they have done with the help of World Bank loan, actually World Bank loan, they have a revised the program as a revised national TB control program. Then subsequently today the program become the national TB elimination program. That way the program is grown. With the loan they introduced, if the program is not controlled properly TB, the another next generation will be the big TB burden and the financial burden they have to face. For that, this program is well structured in India and other globally. It's a well structured program compared to the other program. The program responsibility to cure the patients. For example, the other program, they will supply the drugs to the patient. They have to take their own care. But in this program, special program, the health system responsibility to cure a patient. If patient is identified as a TB or diagnosed as a TB program's responsibility, they can't say any reasons patients are not coming or they are not consuming the drugs. They can't say any reasons. The health system responsibility to cure them and send them out. This is the well-structured program. But what we are facing today, still, if you give free treatment, free diagnosis, all the services, but still patients are not able to treat properly because still they are not able to come forward for the treatment. There are issues. It's not only the health problem, it's more on socio and economic problem. It's well-known fact that, well-known fact. Um, so what in this country there are very few TB research centers. One is an ICMR, Indian Council of Medical Research. They have many centers disease specific. There is a one center in Chennai, that's the National Institute for Research in Tuberculosis. This center conducted series of research. I'm talking about the research. Research on tuberculosis. The main mandate to control clinical trials to establish policy for treatment of tuberculosis, both pulmonary and extrapulmonary forms, and again sensitive and resistance TB. Then in the beginning there was a 24 months treatment. The duration for TB treatment for 24 months. With their effort, they are able to reduce the treatment duration to the 6 months for both sensitive and resistant TB treatment. In my lifetime, when I joined in ICMR, National Institute of Research in Tuberculosis, that time there is no diagnostic facilities for drug resistance TB. Means like now many people, maybe the medical people knows what is the drug resistance TB. The drugs can TB is 100% curable if they take the treatment full course with in on early diagnosis, and if they take drugs and right drugs and right time, it's 100% curable. But the patients are not taking treatment properly. Again, it's a combination of therapy they have to take. It's not the one drug, the combination of drugs they have to take. If they take right dose, right time, and early with early diagnosis, it's curable. If patients are delayed, if they are not taking treatment properly, then there is a chance to develop the resistance. If they become the resistance TB, it's very difficult to treat. In when the program is introduced as a revised national TB control program, that time there is no diagnostic facility for drug resistance TB, and there is no treatment. But today we developed, like it can be diagnosed within 1 hour time. There is a diagnostic facilities are grown. Like in the beginning, there is only microscopy facility is there, X-ray was there, but today the molecular diagnostic tools are available, rapid molecular diagnostic tools are available, and culture again solid and liquid culture. Sorry, can you hear me? So the diagnostic facilities are grown like this one. Today, the multi-drug resistance TB can be diagnosed within an hour. And again, treatment also available, both sensitive and resistant, 6 months treatment. The cure rate was more than 90%. The patient started, the chance to cure was 90%. That way, the program is grown. But still, the challenges are medicine alone, it's not possible to cure or eliminate TB. Now, the globally, TB, the global community, World Health Organization and other communities, with the government of, and again, government of India, they are aiming TB to be eliminated in 2035. This is for the global goal. But government of India, the Prime Minister is announced TB to be eliminated 5 years before, like 2025. They thought it should be eliminated 2025. Already we are in 2025. There was an argument whether it's possible to do that. If you want to make it possible, what we have to do, all it was discussed and debated. Government is given high priority for the TB elimination politically and in the scientific community. Now they are saying it may given 5 years grace time. If not possible today in 2025, 2030, it should be eliminated. Government is given high priority. It's a lot of fund available. They have a like a innovators meeting and many things. Government they are ready to invest. They have already invested for the TB lot. This is going on this way. This was the medical community. The other side, medicine alone, it's impossible to cure this disease because it's a social and economic problem. Government has taken so much of effort on this economic impact. For example, this TB symptoms are very mild. Nobody will think cough is a major symptom for tuberculosis. Nobody will think cough is going to kill them. So for that, there are a lot of studies done in India. Again, NIRT, the Department of Socio-Behavioral Research, care-seeking behaviors. Patient will not come for the treatment with its symptom. The symptoms are like a cough. Cough, nobody will think it's very serious. Previously, the program 3 weeks cough and 3 sputum test for to confirm tuberculosis. The program is changed today. Any duration of the cough, any duration of cough become the symptom, can be suspected for tuberculosis. They have to test it and confirm whether TB or not. That is that they changed the policy. Again, previously they have a 3 sputum test needs to be done to confirm tuberculosis. But today, one sputum is enough for the test the confirmation for tuberculosis, start the treatment. Previously, they have done 3 sputum. One is on the spot, and again overnight sputum, and again on the spot. This 3 sputum needs to be done, but they changed the policy. What I want to say that care-seeking behavior of the patients is a problem. Like people will not come for the treatment, and they didn't think that symptoms are very serious. If they come, if they diagnosed, it's a very stigmatized disease. If they say TB, they won't accept or they won't believe their diagnosis. Then they will go to the other private practitioners. This is the behavior. This behavior create the economic problem for the patients. What they will do, they will go to first for the symptom relief, they will do first home remedy, or they will go to the pharmacy to buy the drugs, they will spend money, or they will go to the private practitioners, they will take the treatment, they will spend the money, then finally they'll reach the TB diagnosis. They spend all the money for the diagnosis. We call it as a shopping for diagnosis. The patient have a symptom, they want to confirm diagnosis, they will visit the so many hospitals. Finally, they will end up with so much of loss. Then they diagnose the TB and they start the treatment. When they start the treatment, it's very difficult for them to spend money to buy the drugs for the poor people. Then they will reach the government hospital for the free treatment. To avoid this, government is made all the hospitals, including private hospitals, free diagnostic and treatment facilities. Patient can enter any, they call it as a point of care test. They can enter any health system or any level of hospital. It may be primary health center or tertiary health center or private clinics or tertiary hospitals. We have to diagnose the TB as early as possible. And if they diagnosed in the private hospital, in the government, it's well structured. When they diagnosed TB, they have to start the treatment. They have to register. TB register is there. TB treatment cards are there. Then that patient to get the treatment closer to the residence. Then the program should follow up to the completion of treatment. If they enter the private, it's again notifiable disease. Private sector, to anybody diagnosed in the private sector, they have to notify to the government, and they can take the drugs from the government and free treatment to be provided to the patients. Maybe they can keep patients with them in the private sector, because patient are not willing to go to the public. They can retain the patients with the private clinics, get all the facilities from the government. These are all like public-private partnership, public-private mixed models. They developed, and this way they are treating the patients. Then another one, still patients are not coming for the treatment. They have to complete the treatment for uh, currently minimum 6 months duration. They have to complete the treatment. Again, the research is going on to reduce the treatment duration. Already there is a moxifloxacin regimen is available. They have proved 4-month regimen is effective to treat TB, but still it's not implemented in the program. Again, we recently we had a discussion. Can we reduce further to the 2 months treatment for tuberculosis? But in the program, 6 months treatment is there. Still, it's the program is struggling to make the patient to complete the treatment. 2 months they will be better with the treatment, then they will stop themselves. So it's called it as a last. Previously, it's a default. Now we said we can't blame the patients as a default. You have to take the responsibility. Program should take the responsibility. They change the terminology to default to the last follow. Patient is a default. You don't blame the patients. Then they change last to follow. I didn't follow the patients. It's called the last to follow. So patient should be followed, and to make them to complete the treatment. For that, what program is done, they are given money. Somewhere we have to attract the patients with some interventions. They are giving money to the patients. If they are coming for regular on treatment, previously it was the 500 rupees given to the patient to come for the regular treatment. Now they increase to the 500 to 1000 rupees every month to patients come and complete the treatment. In addition, other social support counselings provided, nutritional support. They are encouraging patients to take nutrition so that they will improve the quality of life. This is the program. Now, what I'm emphasizing, the TB. If anybody get TB, there is a huge economic impact. For example, if they are not coming straight away, go to the government facilities for the free treatment, they will spend a lot of money for shopping for diagnosis before confirm as a TB. First, they will go to the private clinic. If the doctor says that you may have a TB, then they will change because of the stigma. Oh, I'm not that. People will say that I'm not that person, that kind of person. It's not chance to get TB for me. Then they will go to the next hospital. They will spend some time for the antibiotic. But TB will not be treated with any normal antibiotic. They need combination of therapy with the very specific for TB diseases like isoniazid, rifampicin, ethambutol. That drugs they have to take a combination of the drugs only. It will work. Otherwise, normal antibiotic for cough and these things will not work. So then, like this, they will spend a lot of money. Finally, they will end up no money, no cure. Then the health will deteriorate. Finally, they reach the hospital. The people will say that you are look like a TB patient. Better you go on TB diagnosis. Then they will reach. So that they need a lot of interventions to make them to aware about the disease. They have to reach the hospital for correct and accurate diagnosis, early diagnosis. If they are early diagnosis, there is a high chance for the cure rate. Otherwise, the delay in diagnosis, there is a high chance for cure, but the quality of life will not improve. So this way, they are spending a lot of money for the diagnosis. Next step, if they diagnosed, they make them to complete the treatment also very difficult. See, there are chances they may face a drug-related problem, financial problem. For example, they in the breadwinner in the family, they have to work and earn money for the run the family. If they become sick, they take the treatment. If they are not able to, due to the illness, due to the treatment, if they are not able to go for work, it's very difficult to make them to complete the treatment. People may be thinking there are technology, there are medicines, there are innovations, there are discoveries, but still patients will not take the treatment. This is a known fact. So that problem, see, medical people, doctor will think that they have to treat the patient, but other socioeconomic problems, it's not possible for them to solve. So during the treatment, there is a problem. Then once they complete the treatment, again there is a chance for recurrence. Means they may get, there is a chance to get it again TB. That's again recurrence. There is a chance. Sometimes the failure to the therapy. Sometimes if you cured again, they will get the TB. That may be sensitive and resistance. These are our full path for the patients. Again, we have done study. If they are delayed in if early diagnosis, their quality of life will improve. They can survive. Survival will be the same. Like probability for survival after cure will be the same for the patients in the early diagnosis. If the delayed diagnosis, the patient may be cured, but they will die faster than the non-TB patients. This again, they will faster means 2 years early they will die compared to the non-TB patients. These are all research we have done in other aspects. More than medicines, we need to take care for early diagnosis, improve the quality of life, care-seeking behavior change, economic impact like loss needs to be complete. Then again, this TB program is not only helping for get out from the illness, but again this will help for the economic development of the individual, family, and the country. How? Because this already in the introductions are mentioned. It's like more marginalized people are getting this disease. It's a very closely linked with the poverty. Those who are living below poverty, they have a malnourished, their living conditions are assuming so overcrowded, and they are exposed to this environment where, because these airborne diseases, where these patients living overcrowded places, any TB patients cough and sneeze, the bacteria will come out. When they breathe, those who are all breathing, they will be at risk. These marginalized people are more exposed for this environment. They are high chance to develop the disease. Again, another added risk factors, they are malnourished. Those who are living in the below poverty or not taking good nutritious food, they are high risk. They are high chance to get the develop the disease. So if they are already living below poverty or marginalized, then it is further deprived the economic condition of that individual. So this is again main, if you want to stop to eliminate or eradicate poverty, this TB to be controlled. Otherwise, this will be this a circle, like poor people, they will get the disease. They are not able to go for work. They are not able to earn money. They are not able to eat properly. Then again, they will get the disease. Then they will spread the disease. It's a cumulative process actually for the poor people. But now current, this is what the old theory. So poor people will get and they will become further poor. And then this it's nothing new. It's a in 2000 world TB day theme. They fixed stop TB and fight poverty. If you want to poverty elimination, it's indirectly to improve this economic development of this country. We need to invest money for the TB control, because the TB contribution to poverty is a very high. So they made, and they have taken so much of effort. Other side, now it's a new things are coming, new science. What happened? The rich people are not eating properly. Rich people are malnourished. The environment, people living with the air conditioner room and all, more vulnerable for the tuberculosis for rich people. Then science also changing now. So a lot of things that's going on. Then now what we are thinking, it's not the single sector, or we can't work like a TB control program alone. It's not possible to do that. Again, health program alone, it's not possible to do this, achieve this goal. Already government is recommended this should be integrated, the health program, all the health program. The HIV people are very high chance to get tuberculosis, like 200% chance for the HIV people to get tuberculosis. The HIV program and TB program to be integrated, like all HIV people to be screened for tuberculosis, all TB people to be screened for tuberculosis. That they have already integrated. Again, further, all diabetic people have a high chance for the tuberculosis. Then the diabetic patients program to be integrated with the TB control program. Then elderly people, elderly, that aged population have a high risk, because they have a the immunity was low, and they have other comorbidities. That elderly people have a high chance to get tuberculosis. That geriatric population, the OP is to be integrated to the TB control program. Now many people are getting this infertility because due to the tuberculosis. That reproductive health program to be integrated into the TB program. The other program, like this neurological problem or kidney problem, they have a very high chance, because they are taking the medicines. So they have their immunity is low. They are, when they take the medicines for other things, that TB will come again. In this country, almost 50% of the people have a bacteria in their body, but with their immunity, with their good nutrition, they may not develop the disease. But if their immunity goes down, then there is a chance to develop the disease. But now many people, they are high chance to develop the disease. Then the government is already implemented, like high risk population, like household contacts of TB patients. And this all, whatever I mentioned, that HIV patients, diabetic patients, geriatric patients, kidney patients, or immunely suppressed patients needs to be given chemoprophylaxis to prevent the TB. For that, again, we can't give the previously the treatment was no test and treat. Means that LTB, latent TB infection, means those who are in already bacteria in their body to be cleaned with the medicines. That is a chemoprophylaxis for the tuberculosis. There is an INH treatment for 6 months. Now 3HP, another treatment for 3 months they have developed. These already patients have a symptoms, they are sick, they are not able to take the treatment. We are not able to make them to complete the treatment. This is again big challenge for the chemoprophylaxis, like preventive therapy for the TB patients. This is again big challenge. We are trying to prevent the TB. Now the previously that tuberculin skin test was there. Many people knows that this or skin test we can identify whether tuberculin infected. That again, in this country we have a 90, more than 90% people BCG vaccinated. This vaccination may give the false positive cases. So this TST is no valid today, then new test is come up with the SciTB test. This will help for the false positive by the BCG vaccination. That government is already implemented. Now they are aiming to do the SciTB, rule out the find out the LTBI, and again further step we have to screen for TB test with the TB test. If those who have a LTB positive, further we have to identify TB or not, then we have to go for the TB treatment. Again, now previously there is no TB treatment. We are not getting much resistance, but people are treated almost more than 100,000 people every year treated. Then there is a high chance for the resistance TB. Then we have to rule out the resistance TB. Then you have to start the treatment. There are diagnostic tools are available. This molecular RT-PCR, PCR based test, rapid tests are available to diagnose TB, whether they have a mycobacteria tuberculosis, then whether sensitive and resistance tuberculosis, that facility we have, then they can diagnose accurately and start the treatment. This is a growth for the medical line. Similarly, for the socio-behavioral side, again, Dr. Karikalan is heading the Department of Socio-Behavioral. They have done a lot of studies, patient support system, and the counseling and awareness program. They are trying to game based. They want to use the technologies to make awareness. And again, what is that? Adherence strategies. Adherence strategies to make them. One is like make aware through the technologies. People can come forward for the diagnosis. Once the diagnosed, to make them to complete the treatment for adherence strategies, there are technology like this reminders, the alarm reminders, 99 dots, or patient taken treatment, and they can give the missed call, and there is a system will change the color if patient is taken treatment. If they are not taken treatment, the color will be the different. Then the health system can give the calls to patients to reminder calls to make them to take the treatment. These are the technologies. Again, social economic aspects. Again, patient, we are giving completely free treatment and diagnostic facilities, and there are incentive to the money to the patients to complete the treatment. But still we are not able to achieve, and there are big challenges. What I want to communicate in this forum, there are now this communication, we achieved the peak. Actually, this communication sector has changed. This mobile phone is there. What we faced in the before 70s, communication is a big problem. But today, with the interventions, communication can be very fast. We can communicate anything just a minute. Like for our experience, if you want to publish any research evidence, it will take 1 month to send the abroad, and it will take 1 month to get the acknowledgement reminders. It takes very long time. But today these communications are very easy. Communication is grown like anything. Similarly, what we are thinking, we have to introduce the technologies to the health sector, so that it will help to the achieve the goal. For example, like what I mentioned, that adherence strategies, 99 dots, ma'am, and other things. We have like a diagnosis, like for today TB, the diagnosis is grown like anything. So we have to introduce the technologies to the health sector that will help to achieve it. Government of India already taken efforts. They made this health technology assessment in India. In that, they made like they are helping for Midtech Mitra, many things. They are helping new intervention. They can registered patent, and they can develop with the coordination with the industries. They have taken, they have arranged so many meetings, like innovators meetings, calling companies. They can the innovators. Recently, Dr. Karikalan attended the new meeting in Delhi. They are called the innovators ideas. Then they can link with the companies. Companies can help to the develop the strategies, or technologies to help the TB program to improve it. Sir, how much time I have?
5 minutes, sir.
Yes, sir.
Okay,
Another
okay.
5 minutes, sir.
Yeah, I will another 5 minutes. Sir. This technology, where I'm in charge for the regional resource center for health technology assessment. any new interventions already proved it's clinically effective. So far, people know that IMR is infant mortality rate. But now this new IMR is a innovation mortality rates. In this country, the other advantage is we have a huge population, new ideas, they're developed by the population, new ideas, new innovations are there, but still that innovations are not brought into the population benefit. Many innovations we are not able to implement it because it may not come out or it may not be recommended to the program, or not given guidance to the government to implement it. Now this government new initiative, health technology assessment in India, this platform, any proved, clinically proved interventions to go for population benefit. Towards that goal, this medical fraternity or industries, they can brought their innovation to the DHR. They have a platform they can register it, that will given to the HTA regional resource centers and hubs. They have to undertake this analytical exercise and help the government to implement it. It's not the stop the intervention. This intervention should be beneficial, not for universal implementation. It may be beneficial for the one segment of the population, or it should be implemented the way it should be beneficial to the population. This way they are working on that. We are helping. So any medical colleges or any new interventions or innovators, they can approach. It's again I'm saying it's already proved, clinically proved interventions. It should go for implementation to the government is ready to invest, but we don't know where we have to invest, how much needs to be invested, and what is the rate of returns on that. See, people may be thinking that why government is aiming for that, but actually there are four result will come, like always the new intervention have a more cost. But so far, what happened, how the decisions are taken, so low cost, more effect, this will go for implementation. If it's more cost, less effective, we can't implement it. More cost, less effective, we will reject it. More cost, more effective, we don't know how much more. Less cost, more effective. It's very difficult to get this kind of interventions. Less cost, less effective. So far, we are implementing because the cost is concerned. Whatever less cost, we don't bother about the effect. So far, the policies are there. Now, we have to move to more cost, more effective, because we need more effective in terms of effect means reduce mortality, increase the quality of life, increase the survival probability. The ultimate aim of this health sector is people should live more life with the quality of life. For example, I'm saying, why don't you people not living 100 years? Why they are dying before 100? The life expectancy today is 70 plus. Why not 80 plus? We have to increase the life expectancy with improve the quality of life. So for that, we have to introduce the new interventions. Then in this country, we have a lot of new interventions are come up that needs to be implemented. For that, we have to tell the government whether it can be implemented. If implemented, what is the returns in terms of life saving, improve the quality of life. Then there are these economists and other epidemiologists and public health experts. They are developing indicator like quality adjust life years, disability adjust life years, to gain one quality, how much we can spend. That also people are working on that. Again, it's going to be a big way. Like in developed country, this health technology assessment is well established, but in developing countries, still in the progress in the developing stage. India has taken so much of efforts. I hope it will come in big way. For that, we need to collaborate. That why I'm requesting this platform. We need more in-depth discussions on what is health technology assessment, what are the new innovations, so how we can implement it. All these things we can further we can discuss. I will stop here. Any clarification questions, I'm happy to answer. And once again, thanks for this opportunity, particularly Professor Suresh Maria Selvam sir, linking this platform. So I request everybody, any help from ICMR, from our side, we are very happy to provide, sir. And again, we can more collaboration for research, more collaboration for innovative research or discovery research, or more innovations for the implementation research and policy research. We are happy to do that.
Thank you, sir.
Thank you.
Sir, we'll have a question session after Karikalan, sir.
Thank you. So thank you, sir, Muniyandi, sir. Beautiful. So I have few slides, just, I thought Muniyandi sir will say about ICMR. So there are some slides which I want to show you in general. So can we go to the screen, full screen mode, sir? Yeah.
Wait 1 second.
Thank you, sir. Yeah. So can we, Tamil la pesalama ellarum, everyone understand Tamil, sir?
No, sir. I think better in English, sir.
Okay. Good. So actually, I think my session could have been first. I have very basic information. Muniyandi sir has talked about advanced research in terms of technology and everything. Anyway, I will try to cover up some basics which sir was not touching. So, by the TB, we all know that sir has told it is a very important problem. Whenever we talk about pandemic, COVID pandemic, everyone knows. Pandemic is something which is affecting people across the countries and societies. It is universal, and it doesn't leave everything. So on the pandemic term the TB is one of the most important pandemic. The previous slide, sir. First slide. Yeah, you can go to the first slide. Yeah. So if you take TB or no, the next one. Yeah, sorry. 1 billion. Yeah. So TB consequence these 1 billion people who have been killed by TB it is after 1882 it was discovered. It was discovered by Dr. Robert Koch in Germany. So after that TB has killed almost 1 billion. It is almost equal to 80% of the population of our India. Globally, it has killed tuberculosis. And every day it takes thousands of life across the world, and it is a truly a pandemic disease. Even COVID we were able to control. TB we will not be able to control. It is a highly adaptive disease. It has grown up with humanity and animals. It will be very difficult to control this disease, and this is a socio-economic disease. TB it is not just an infectious disease. It has very deep connections with our culture as well as our socio-economy. So this is the scale of the consequence of TB. 1 billion has been killed so far. Almost one entire country has been wiped out by this disease, mostly young population. Next slide, sir. So in terms of economic burden, we, myself and Muniyandi sir, right now we are working on a paper. So we were able to estimate that in terms of GDP, we have a latest data on 2021 TB mortality data. We have almost some 3 to 3.7 lakh people who died of TB in 2021. So with that we were able to ascertain how much GDP loss will be happening for the country in Pakistan. For that particular year, $9 billion almost India has lost. It will be losing in terms of GDP loss. So such is the scale of TB death, which is scale of the economic loss which TB is inflicting on our country. 9 billion for 1 year. If you calculate for some 10 or 15 years, you need to look into the scale which TB is causing. Globally, it leads to some trillions of dollars we can save. So there is a study from USA, the Stop TB, which says that if you invest $1 for TB burden, the yield for you will be $33 in return. This will be a bit higher in these days. It is an old estimate. $1 if you can spend on TB, if you are preventing one TB disease, the yield will be almost $1 investment is equal to $33 dollars in return. Next. So as I told, the reason why we are celebrating this World TB Day, it was in 1882, some 143 years before Robert Koch, a German scientist, he discovered that TB is caused by this particular bacterium which we are seeing in this microscope. TB discovery it is a truly a great moment for the history. When TB was discovered, it shows there were a lot of myths about our health and everything. The germ theory was born when TB bacterium was discovered. அதுக்கு முன்னாடி we never heard a germ theory. We thought that diseases is caused by TB is caused by our karma and all those things. Only after this bacterium was actually discovered the age of antibiotics started. So there are two important things in the world history which improved the life expectancy of human beings. One immunization. We know that Edward Jenner standardized it. Next in the TB bacterium identification. These two things actually saved billions of lives after discovery. Only after it was discovered we understood how it could be controlled. Otherwise we were just beating around the bushes. So in 18th and 19th century 1 in 7 person in the world died of TB across the world. 1 in 7 person. TB is the major contributor for lower life expectancy. நம்ம சுதந்திரம் இருக்கும்போது பார்த்தீங்கன்னா நம்முடைய லைஃப் எக்ஸ்பெக்டன்சி it is only 30. அப்போ நம்ம we are having almost 70 is our life expectancy. Reason, one of the main reason culprit is TB. Globally, life expectancy has improved due to immunization for various diseases, as well as we discovered antibiotics to kill this bacterium. Only after that the life expectancy drastically improved across the world. Next, sir. So I will come to the burden, latest burden of TB later. Just I want to give some very basic things, awareness thing. The main thing is, we need to know what is TB, how it is caused, what is its impact in body. TB, it can affect any part of the body. Like I told, Mycobacterium tuberculosis is one thing which creates TB. There are different types of bacterium. This Mycobacterium tuberculosis is the predominant one, and it predominantly affects your lungs. Almost 70 to 80% it affects your lungs, and it can affect any part of the body except the dead tissues. Except your nails and hair, the TB can affect anywhere. There are spinal TB, your eyes can get TB, your brain can, meningitis will be there, renal TB, genital TB, uterine TB, and then lymph node TB. There are any part you identify in the body, TB has, and the predominant is only in your lungs. So what we call it as pulmonary TB, it affects your lungs. If it is not affecting your lungs, then it is a extra pulmonary TB. But there is a problem now. Previously 80% of the TB pulmonary TB only affect the lungs, but almost in the past 10 years 30 to 40% of the TB it is becoming extra pulmonary TB. It is very, very difficult to diagnose extra pulmonary TBs. When TB affects your spine, we will think it is some kind of osteo problem. We think it is some kind of bone marrow problem, or and then we will not be able to diagnose. Lungs, we have typical symptoms. I will show what are all the symptoms of lung TB in the next slide. So these are the two classifications of TB. So yeah, next, sir. Next. Yeah. So when it infects the lungs, when the Mycobacterium infects the lungs, it goes inside and then it stays there. It creates inflammation. And it usually in the pulmonary TB, it usually the main route of transmission is airborne. Droplets are the infected person, if he coughs, then the droplet spreads out, and then if you are in constant touch with that person, this is not like COVID immediately transmission happens. But transmission whenever you have a consistent contact with the person who has TB in a closed space where he is repeatedly coughing, then you will get the TB. So one infected person he can transmit up to 10 to 15% the TB bacteria. So that is the most important here. So if you are untreating a TB patient, he can transmit to almost 15% the same bacteria. That is the reason crowded places will have more TB. Places like Chennai, North Chennai will have a lot of TB, due to slum areas where you have more congestion. You will Madurai it has the highest burden. Throughout India, India when you take India, Delhi has the highest prevalence of TB, very populated. Mumbai has more TB, and then Lucknow has more TB. Wherever there is Bangalore has a high burden. Wherever there is a dense population, TB is there. It is a airborne disease, and then naturally it gets transmitted. Next. Next. Yeah. So these are the typical symptoms. This is very important. So pulmonary TB, you will have cough for more than 2 weeks. These are symptoms. We have to go and check. When you have cough for more than 2 weeks, and then if you have fever and night sweat, and then if you have loss of appetite and weight loss, these are typical symptoms. where we should be able to go and check our sputum. So these are the kind of gold standard: loss of appetite, weight loss, fever and night sweat, cough for more than 2 weeks. But this is only for pulmonary TB. Non-pulmonary TB, extra-pulmonary, like I told, if you have some kind of swelling in your lymph node, or neck or a swelling, if you have a severe bone pain, and then in addition you are having fever, then we should also suspect TB. Extra-pulmonary is very difficult. But pulmonary is the major thing right now. Pulmonary on the 60 to 70%. So whenever we have persistent cough, whenever we have fever, loss of appetite, the good thing is don't consume antibiotics directly. We have to go and get a consultation from a doctor. Like Muniyandi sir told, we have a lot of quick diagnostics are made within 24 hours, 48 hours. They will take an X-ray and then they will say whether you are right or not. Now there is a pattern symptoms are not. We did a survey in India and Tamil Nadu, almost over 4 to 5 lakh people we screened for TB. We found that almost 40% of the TB patient doesn't have any symptoms. This is one emerging problem in public health. If you take diabetes, previously we say the diabetes person will have urination and then he will lose weight, loss of appetite. But most of the diabetes and cardiac patients, they don't have any symptoms these days. This asymptomatic thing is becoming a problem throughout public health, whether it is COVID or tuberculosis. Tuberculosis, it is very surprising. 40% of the people doesn't have any symptoms. Only if you take X-ray, they will be. You will come to know that they have TB. So, but anyway, remembering the symptom is very important. Even though they may not have cough, they may have fever, they may have loss of appetite and weight loss. So it is a complex thing. So we have to remember the symptom as well as, whenever you have other cough related symptoms, we should be very helpful. X-ray, if someone suggests to take an X-ray, don't hesitate to take. X-rays bring out a lot of, problems in TB. X-ray has become a very important thing. Most of the patients we are identifying, almost 40% is through X-rays. Next. So, this is the history. The TB has a very important relation with India as well as with Tamil Nadu. So, this is called a sanatorium. In those days, before 1940s and 50s, whenever someone gets a TB, they will be isolated. They will be taken to a sanatorium. In Chennai, we have GSTM. In Tambaram Sanatorium, lot of sanatoriums are there across country. In Madurai, we have Toppur. Everywhere in any part of India, there will be sanatoriums. When any TB patient gets sick, they will put him. At the time, there was no antibiotic. So they will be given fresh food, warm food, and then the air circulation, they will be placing them under trees and everything. So they improve the lung health using the sanatorium approach. But problem we don't have enough space in sanatorium, and you cannot treat a patient lifelong in sanatorium. It is impossible for the patient to live in sanatorium when there is no cure for TB. So this is called as the age of sanatoriums. So our institute, ICMR NIRT, National Institute for Research in Tuberculosis, we did a phenomenal work in 1950s and 60s. At the time, it was called as Tuberculosis Chemotherapy Center. It was established by the WHO in collaboration with the Indian government. So there were two stalwarts in our, scientists in our institute. So they discovered this. Go to the next slide, sir. So they conducted so in 1956 we started this chemotherapy center, and then it was converted into TB research center. Now it is called as National Institute for Research in Tuberculosis. Next slide, sir. So in 1956 our institute undertook this very important study. It is called as Madras Classic Study. It is one study which has prevented millions of deaths across the world. It is a true contribution of our Indian contribution to the global, public health. Especially, we should be very proud if this comes out of Chennai, from many of our own place. So this is called a Chennai Classic Study, where our scientists, at the time, our founders of TCC, they told that, you don't need to treat TB patient in sanatorium. I showed in the previous slide how people are, just put in a sanatorium. We showed that TB can be treated well when you are staying in your home on an OP mode. You don't need to isolate everyone. You can just treat the patient as like a normal patient. No need to stigmatize them. And then we reduce the treatment period from 24 months to 12 months, and then subsequently to 6 months. This was a game changer. We showed that TB patients could be treated just like another patient, and this can be done just like it's easy. You take 6 months of treatment, 12 months of treatment, it is finished. No need to spend your life in your sanatorium. So that actually, that particular thing, actually is throughout the developing world, it had a huge impact. More and more patients were treated with this, our home-based treatment, and actually it saved crores and crores of people. So this is one true contribution, global contribution. I think nothing is comparable to this contribution which India had made in any field, whether it is medicine or engineering or whatever it is. India played a very important role in saving millions of lives. Till this date, this has saved this. A small study, a thoughtful study. We should be very proud of. So this is called as Madras Classic Study. It is cited throughout the world. So this has brought in a lot of fame for our institute. Wherever you go, if you say TRC or TCC, you are well known. Whatever, wherever TB research happens, TRC and TCC is known. Just I wanted to share this important thing. Next, sir. So this is the, our domiciliary treatment, where we go to the home, where we see that we supervise the patient, what we call it as DOTS, Madras study. We supervise the patient, we ask them to take the treatment, and then we ensure them that he finishes the treatment. So this simple home-based strategy, this simple supervision has actually reduced millions of deaths. This is the true innovation. Innovation means, it doesn't need to be, you have to build huge machines, you need to build on all these artificial, everything is fine. But still the human touch, yeah, community-based approach is something, which is very important for public health and, education and rest other thing, very simple things, they could be very novel as well, very innovative as well. Monitoring a patient when he is taking the treatment, only it can save millions of lives. That is what proved in our study. Next. So now this is a bit of a history. I will show right now what is the problem. So I told in 1960s when we showed that, treating a TB patient, it has 90% success. If you treat 100 TB patient with our antibiotics, almost 90 to 92%, minimum 85% will be cured. But still, when the TB is remaining very challenging for us, even though we have a very, very effective. So even though we have very effective anti-TB treatment, still when the TB remains the greatest challenge. In 1960s we proved 90% could be cured by antibiotics. But why we are unable to eliminate? Next slide. So if you take the global TB, scenario as in after 2020, next slide, sir. Yeah. So throughout the world, there is almost we have 10 million cases, 10 million new cases of TB. 10 million new cases. Just a minute. Give me 1 second. So we have 10 million cases, almost 1 crore people are affected by TB every year. And even after we did our, all those great studies in 1950s, still India tops almost 2.7 million people. Last year it was 2.5 million. 25 lakh people are infected by TB every year in India. Out of that one, even in a drug, like Muniyandi sir told, there is a thing called as drug-resistant TB. People who don't take medicine properly, they develop resistance. It is one of the most fatal disease form. And in MDR TB also, 26% of global cases is from India. The highest TB mortality is also from India. Globally, almost 10 lakh people die of TB. Almost 1 million people die of TB. In that almost 3 to 4 lakh, less than 500,000 people die of TB in India. So India is the epicenter of TB pandemic. Even though the population wise, if you compare out of 1.3 billion, it is very low. Other populated countries doesn't have this much amount of burden. India, 25% of any TB burden, whether it is DRTB or DSTB or TB death, it comes from India. So this is a matter of concern. That is because the reason we have good medicines, everything is given by free, as sir told. We have a lot of innovation, but TB is a social disease. Whenever it is a manifestation of our, poor socioeconomy, poverty. I will talk about what are all the determinants of TB. There was a viewer who is asking whether it is hereditary. So I will come to what is the main risk factors which cause TB. So this chart shows that we are very far away from eliminating TB. Even though we have done wonderful works, still the risk factors of TB puts India in a chart where, it is a matter of shame also, Without eliminating TB, we cannot call ourselves a developed country. There are other diseases, there are cardiac diseases, kidney diseases, cancer, everything is coming up. Why we are focusing more on TB? It is a socio-economic disease. Unless you eliminate TB, we cannot say that there is equality in any country. Other than that is very important. Next. So these are the mortality. If you take the mortality rates, you see that the brightest color, it shows that we are almost equal to some of the African countries and Central Asian and Mongolia and Southeast Asian countries. If you look into the Western countries, European and American countries, it is very, very, very little. So that shows that stark difference. Wherever a global South, if you take the global South, it is mostly affected by TB, except in Middle East or somewhere. That is the reason it is a poverty disease. If you take the global North, except Russia and these things, European and American countries, they literally have no TB, very, very minimal. And even their present TB is due to immigration and rest of the thing. They have only latent TB. They have no active TB disease. So the burden, 90% of the burden is by global South. It shows how socio-economy and the development of a nation is interlinked with TB. Next. So within India, next. Within India, like I told, we have almost some 2.7 million cases in this country every year. So this is the way, the thickest on the Uttar Pradesh and northern and western Indian states, they have the highest burden. So when you take the southern states, the Kerala is faring better, but all the Andhra, Karnataka, Tamil Nadu, and Telangana, everywhere you find, it is a moderate prevalence. Uttar Pradesh has the highest, followed by Maharashtra. This is 2021 data. Still, it is relevant. Almost 20% of the cases in the country, it comes from Uttar Pradesh. Tamil Nadu, it is almost 4% cases. But we should not estimate this particular, notification with the burden of TB. When it comes for burden, that is calculated in a different way. Because even though Uttar Pradesh has 20% of TB cases, its population is very huge. It is almost 23 crores. So we have to standardize. When you standardize, Delhi has the highest prevalence. For the population adjusted, Delhi is having very highest. And all the northeast states, northern states are having very highest. So this almost you see that except a few states in northeast and Kashmir where we have less data, it is widespread except in Himachal Pradesh. TB is increasingly reported. Even though the prevalence there is a difference, so the TB is a wide problem across all the states. There is not a single big state which is away from this problem. Next. So this is the most important thing. This is my topic. So we all know that the TB is caused by Mycobacterium tuberculosis, but it doesn't affect everyone equally. Even though you have, even though you have. Sorry. So even though we have, TB bacterium, it can affect everyone. It affects very unequally. For example, there are some 4 or 5 important risk factors which drive TB, transmission. First one, at the bottom you see undernutrition or malnutrition. So if you take any TB population, almost 50% of them will be having low BMI of less than 18.5. Whenever there is you have a very severe malnutrition, then you have a high risk of getting any infectious disease, especially tuberculosis. Malnutrition plays a dual role. When you have low malnutrition, when your BMI is very low, you are highly likely that you may get a TB. When you have TB and then you are malnourished, your treatment outcomes will be very poor. Mortality is very high among people who are malnourished. Your TB medicine will not be well absorbed when you have malnourishment. So unless we address this, malnutrition and underweight and some other thing, the TB will be a very challenging thing, because medicines don't work unless you eat properly. So that is the, even for prevention, malnutrition is very important. The next one is alcoholism. So alcoholism, almost 10% of the entire TB cases could be attributed to alcohol use. I mean alcohol abuse. It should not be confused with a kind of a regular alcohol use. Those who are highly dependent on alcohol, along with smoking, they are highly likely to get TB, because their immunity is compromised when they are highly consuming alcohol and very dependent on them, and then they are already malnourished then it is a problem for them. And diabetes, like Muniyandi sir told, the diabetes is becoming a problem where your immunity is compromised. So there is a theory which says that diabetes actually decreases your immunity and your co-infection is increasing. HIV is a problem. HIV, right now we have controlled a lot, but HIV is a big factor for driving the TB infection. So when it comes for social factor, we have to look into undernourishment, alcohol, smoking, as well as our diabetes. Unless we address this one, we will not be able to prevent new TB cases. These are the social factors. So we should be thinking that just giving drugs alone will not help. We have to invest in addressing malnutrition. We have to undertake, throughout India, the rampantly alcohol use is increased a lot. Governments are promoting irrespective of any state. We are keep on saying it is only in Tamil Nadu, we are saying that, it is being promoted, but everywhere it is a problem. Andhra, there is high alcohol consumption. Delhi, even in banned states like Gujarat and Bihar, we come to see news where illicit liquors are come sometimes. So alcohol is a social problem, which is a main risk factor for most of the infectious disease, and TB is a major thing. Smoking we have reduced a lot, but still smoking plays a big role in lung diseases, especially tuberculosis. So these are all the social factors. TB is not a hereditary disease. Surely it cannot come. That is one of the greatest myth. It is a stigmatizing notion that TB can never pass from hereditarily. Only these factors contribute. Okay, there are occasions where an entire family gets TB. The reason they get a TB is not due to the genes, but it is the social circumstance. When you go to the slums of Chennai, you will have family, 2 or 3 generation of people will be having TB, not because of genes, because they are living in the most disadvantaged place, where there is no food, where alcohol abuse is very higher, where there is smoking, substance use, where the literacy is very low, where they don't go and access the health facilities for diagnosis. So all these things contribute to family level TB from son, and you can see the father, grandfather, and sons all were having TB and dying, not due to genes, because of these biosocial factors. Many factors come together, and then so people in those ages who doesn't know what is meant by TB bacteria, they assume that it is a karmic disease. It is not karma, it is the social circumstances which induce TB. We should be very clear about it. TB is pure 100%. It is caused by tuberculosis bacteria, and that bacteria is facilitated by all these factors: undernourishment, alcohol, diabetes, and HIV. These are the things. Next. So this is something. So what should be done for TB? Just I will take another 5 minutes to say, we are spending a huge amount for treating one TB patient. The government is spending almost from Muniyandi sir estimate. We have estimated almost 28,000 will be required for 28 to 30,000 is required for treating one TB patient. Diagnosis is free. So you think that every year India is spending thousands of, every year we are getting 2.5 million cases. We are giving completely free treatment, completely free diagnosis. We should be very proud. Our TB program is one of the largest public serving program. Nowhere in the world was such a fully funded, freely, providing diagnostic and treatment is available anywhere in the world. If you stop TB program from serving free treatment for the next 6 months, then India will be destroyed. Such is the financial commitment we have shown. We are treating almost 2.5 million every year, completely free of cost in a gold standard way. That is something which we all should be proud of. Many people talk about privatization, this and that. That is good, but when it comes for public health, the government has a very big role. Whatever government spends in terms of public health, especially for immunization and TB, it is a huge investment. It is not spending. Whatever is spent for 1 rupee for TB, then the returns are very high. In that way, we have to respect the government public health programs, and then we have to support the program in a larger way, whatever sector we are from. So in addition to whatever government is giving us free treatment and diagnosis, nutrition support, like I told, nutrition plays a very big role in TB treatment. So we did a study in Jharkhand and Chhattisgarh, some of the most underdeveloped states, where we found that, next slide, sir, where we found that if we can increase the weight of the TB patient, for example, if a patient is having a low BMI of 18.5%, very poor, and then if you can increase the weight of the patient by 5%, not 5 kilos. For example, a patient is 50 kg of weight during the start of the treatment. If you can raise the weight by 2.5%, then the death is reduced by 60% probability. You look into the huge impact which nutrition is having. improving the weight by 5% can reduce the TB death by 60% among malnourished patients. This is one of the very good study which we have done, and then we have shown the India and world that providing nutrition is equal to vaccine for TB patient. Without improving their malnutrition status, we cannot reduce TB mortality. We will not be able to prevent TB incidents. So this is the social impact we should be able to do. Government cannot provide free ration. Already government is providing free ration. It is providing 1,000 rupees for all the TB patient for nutrition support. But still that is not enough. Many of the TB patients are from low socioeconomic status. They don't have money to food. Many of them are alcoholics. They spend whatever money we are giving to some other thing. So improving the nutrition is a very challenging thing. For the government is expecting the community support. So providing, this is the big innovation. Innovation comes by the usefulness of the innovation. Technology or whatever technology and whatever drugs we have discovered, they are not enough to prevent or reduce mortality. Only providing nutrition can avoid this catastrophe. So this is one very important study. We have shown the impact of nutrition. Next, sir. So government has initiated something called as Nikshay Mitra, where we are encouraged to adapt TB patient from poor community, where we provide them some per month when we are providing rations or some nutritional products. This actually plays a very important role in reducing mortality, as well as when the TB patient is cured, he will not be spreading the infection to someone. So this is a kind of our institutional activity. The patient consent was bought before we shoot this one, because we want to explain how malnourished the patient, how poor they are. So this is a private thing, not for circulation. Just we want to show what impact we are making. So for per patient, it is taking almost 6,000 rupees. So we mobilize donors. In last year, we have supported some 600 TB patient in Chennai and Tiruvallur. This year, we are trying to get some CSRs and private persons. It is not only nutrition support. Many patients are without job because they are doing very menial job like auto drivers, coolie workers, day laborers, widows. Especially women, are discriminated after they get the TB. So we also try to provide some livelihood support for them. We give them sewing machines. Some of the children affected when they lose their school days, we try to compensate with tuition fees. So all these things are required because TB is a social disease. The outcomes are societal more than individual. So these kind of social support interventions are taken forward by our, and I think, Honorable Prime Minister has taken a very special initiative for TB when considered relatively other diseases. One that has got less attention, but TB has got a very wide attention from this government, which everyone has to accept. So in that way, a lot of progress has been done, but still it is a wide shot. We plan to eliminate by 2025, but still, we are very, very lagging because the social support required is far, far high, which government alone cannot fulfill. So nutrition support is something which we can, aim to, leverage. Next slide. So there are some three or, I just read about this alumni network of Annamalai, one of the oldest universities of our country, which everyone were very proud of, studying in Annamalai, is how much linked to the socio-economic and culture of, Tamil Nadu. We all know very great entrepreneurs, political leaders, everyone has come up from this university. So I think there are a lot of business leaders there, very big people are there in our network. There are few opportunities which I want to just throw up. If we can contribute in a monetary or non-monetary or whatever way. One is that, TB awareness is very poor. Still we feel that we found that 40% of the TB patient doesn't even know what is their symptom is. Even though we are repeatedly talking about TB, very few people know about TB symptoms or rest other things. The awareness is very poor. So we are in a process of, amplifying this TB awareness. Right now we are all reading everything in our cell phones. Everything is done digitally. We want to develop some, good apps and especially for youngsters to understand. People like more interactive, platforms to learn things. People don't listen to you more than 30 seconds. We are living in an Instagram era. So developing some kind of very interactive apps and gaming platforms through which we can disseminate TB literacy is something which we are trying hard. But we find that, technology capacity, still we are trying to collaborate with some IITs and everyone. But, we want, if anyone is interested for these kind of app-based innovations for spreading TB awareness, we can form a group and then we can contribute. Awareness spreading is the fundamental thing. Basically, awareness is needed for TB. And a repeated awareness. It is not a one-time thing. Like COVID, we had for 3 years, we were keep on speaking about COVID. There was reinforcement from all parts. That is the reason COVID testing has gone up and everyone knows about mask after COVID. But we have been talking about TB for 60, 70 years. No one used mask even in our office. Only COVID did that. Reason on the TB awareness is very low. So there should be some kind of innovation, in terms of developing state-of-the-art awareness, applications, software applications where we can engage people very effectively. This is one area where this, IT leaders from your network can contribute. But the next one is about, like I told, nutritional. So nutritional product right now, what we are getting is we are getting from grocery and then we are giving them. It is highly costly, and people prefer different kind of nutritional recipes. So if there is anyone who is interested to develop some kind of cost-effective, cheap nutritional energy, which can have high protein and fiber content for the patient, that will be a good thing. We need to provide cost-effective and easily consumable, acceptable nutritional product for the patient. It could be taken in a research mode. And if there is a way where someone can support a training program for the TB survivors. In Tamil Nadu, we have a TB survivor network, which has some 3,000 TB patients who are cured from TB, mostly women. These are women TB survivors who are struggling to get jobs. They are from very slow socioeconomic status. And then, they require some kind of training or some kind of job placement. They are all educated people. They are skilled people. They need skill building. So if you can provide a livelihood platform for these TB survivors, especially drug-resistant TB survivors, women, that will be a great help for them. Most of them, they are not unable to continue their job after severe TB. This is one area where entrepreneurs can contribute. And then, like Muniyandi sir told, we are developing a small urine-based testing for detecting TB adherence. A patient has to be tested constantly to see whether he is adhering to medicine or not. Right now, we don't have such kind of testing. So we are undertaking a research where we are using a particular urine INH isoniazide reagent. With that one, we will be able to identify within 2 minutes using his urine whether the patient is taking medication or not. But right now, this reagent one we are importing from UK. Per test, it costs almost $8. But this is a non-patented kind of, even we can make this in India, but we have a problem. This reagent has some arsenic compounds where it is banned for import. So if there is any pharma company which will be helping us to develop this urine INH reagent, it will cost less than $1 for us, and it will be a big thing for us to use in our research. We are trying to work with some pharma related resource people and companies. So these are some 3 areas where this network can, contribute in terms of nutritional support, awareness activities, and this research support for these urine INH agent. So these are the areas. In addition, like I told, there is alcohol problem, smoking problem, everything is there. And I think myself and Muniyandi sir will be very happy if you are ready to invest in technology, if you are ready to invest in research, or if you want to donate for a TB patient, whatever it is. So this will be a national, doing, in 21st century when no one is safe unless everyone is safe. TB is not a problem of individuals. It is a problem of everyone. Unless everyone is safe, we are not safe. I think so. With that one, I think I have taken a bit long time. I take this opportunity to thank all the alumni network members of Annamalai for providing this very good opportunity for both me and Muniyandi sir. Thank you very much.
Sir, before you complete,
Yeah.
you said you highlight on the determinants.
Yeah.
Of tuberculosis. Just you can touch on the determinants of.
Yeah. So, I know, sir, like sir told, sir, we have some 4 or 5 determinants. One is poverty. Like I told, poverty is the most important because poverty affects your nutritional intake. 50% of the TB patients are having poor malnutrition. Nutrition is the first determinant of TB. And next one, the next 2 things are behavior related. Your alcohol abuse as well as tobacco use. They contribute almost 10 to 15% of the TB cases, alcohol abuse and tobacco use. And then we have these comorbidities, HIV and TB. If you have, then you are highly susceptible for TB. And one thing which I have not mentioned is the stigma surrounding TB. Stigma, like stigma and discrimination is very high among for TB. For example, a woman, if he gets a TB, a teenage girl, if he gets a TB, or a boy gets a TB, and if he discloses one day, there is less chance he will get a marriage. people have to hide whether they have having TB or not. In workplaces, if they disclose one, they will be sent out of their job. Even though we know that after taking medication within 15-20 days, the transmission stops. Even though TB takes a longer time to cure, within a month, you will be free from transmission. But still, when the TB stigma is very high, it affects a lot of people. It affects the individual, it affects the family, and then it leads to depression. Stigma leads to directly produces stress and depression, and this affects the whole cycle of curing. Unless we address, so addressing stigma, we need to provide awareness, as well as we have to engage the TB survivors. Stigma is deep rooted in India. We are culturally and historically, India is a place where there is a lot of misconception, myths, is happening. Any disease is more stigmatized in India when compared to rest other countries. Especially TB is highly stigmatized, especially in rural areas where the literacy is low. We should be able to combat this stigma. That is why I stressed upon awareness, health literacy, and engaging the TB survivors. Stigma is something a very abstract thing, but it has a very solid outcomes, very negative outcomes for the patient and the community. They lose their job, they lose their family status, they lose their mental health, in spite of knowing the TB is 100% curable. So poverty, alcoholism, smoking, undernutrition, and then another thing is climate change. Suresh sir was telling, climate change, it is becoming a big factor. There are two ways. One, the air quality is very important for lung health. As your air quality keeps going down, your lungs become vulnerable for infection. That is what we saw in COVID. And then lung diseases are becoming a major threat for the India. Right now, in the past 2 years, the lung-related deaths are occupying the highest, mortality rates. It has actually taken forward the cardiac-related death. And climate change has a very disruptive role for lungs. Especially Delhi, that the kind of pollution they have, and when lungs become very weaker and the immunity is compromised, TB is a good opportunity for TB like diseases. Climate change is going to be a big disruptor. And another thing, the climate change, the TB, there is one thing. If you miss 10 TB treatment is for 6 months. If you miss 10 doses of medication, there is highly likely you will develop drug resistance. So we saw in Chennai, at least in the past 2 or 3 years, how many climate disasters have happened. There were multiple floods, there were extreme weather conditions, and all this period, even if it is for 1 week or 10 days, the medicine supply gets disrupted during this disaster time. When there is a huge flood in Chennai, almost for 10-15 days, all medical services get disrupted. And TB patients are affected. They will not be able to get the replacement medication, and TB, within not even 1 day, you should be stop the medication. So climate changes are going to increase the frequency of supply chain disruption in coming years, especially for infectious diseases like TB. It is going to be a good, very bad disruptor. So climate change is an emerging, something which is we are not taking into consideration. It is going to have a huge impact on our lung health as well as our TB. So these are the major social things. I think Muniyandi sir can say
Yeah, yeah,
yeah.
I want to add. Sir, in the social determinants, there are two things. Anybody can get TB, but more chance to get TB, there are two groups. Socioeconomically vulnerable, other one is clinically vulnerable. Two groups. Socioeconomically vulnerable children, elderly, migrants, homeless people, alcoholic and other drug users, smokers, prison inmates, construction workers, socially disadvantaged. We have done a study, the main village and colony have a more TB, people living with the below poverty line. These are the socio-economically vulnerable group. That clinically vulnerable, people living with HIV, diabetics, elderly people in the clinic, and end stage renal failure people, malignancy people, genetically susceptible people, and silicosis, and again aged people, they are high chance. And male, compared to male and female, male have a very high risk. Indoor air pollution, overcrowding and living conditions, vitamin deficiency patients, these are the high risk populations. And again, all so many risks, we can't control everything and we can't address everything. Then there is a Lancet publication. They listed major risk: diabetic, HIV, alcohol, active smoking, indoor air pollution, malnutrition. Then what they have suggested, if they calculated population attributable fraction, which means so many risk factors, everything we can't address that time. But today, if you are aiming for elimination, we have to address all the things. They said if you concentrate for malnutrition, you can eliminate control TB for 27%. That's what now they are again all everybody include Dr. Karikalan sir also again he said malnutrition, if you concentrate and do this malnutrition interventions to reduce malnutrition, you can control 27% of the tuberculosis. So then next is indoor and air pollution and active smoking and alcohol use. These are that's why now government also long back they introduced social determinants of social determinants of health. Now we are doing more, again it's a priority, social determinants of TB exclusively. So these are the factors, these are the determinants of social determinants particularly, and the efforts needs for controlling.
Sir, the environment is also another area which we have to look into it, especially the waste management. Uh, so now the recent past years from the community advisory board, we have discussed how this
Yes.
waste accumulation is again, it's going to be a social determinant in the.
Sir, what happened now? This is a airborne disease. Your lungs will get damaged. They are very high chance to get tuberculosis. So this now again pollution, other environment. It may not be indoor and outdoor environment. People living with this highways. They are saying they are more chance to get lung damage. It's like smoking. They are more vulnerable. That again visible environment change we are now facing. No need to study other environment change. There are environment changes. Then we are expecting, like for example, new risks, sir. What happened at this COVID people, treated COVID people have a high risk for tuberculosis, the question. Similarly, this environment, how it's affect and it will, how it's favor for tuberculosis, again big question. This needs to be studied, but not much science is innovated in these aspects.
No, but one of the studies in and around Karikalan, it shows there is more cases of tuberculosis in and around Karikalan. That's a preliminary study done by one of the institutes. I don't know whether it is published or not, but I'm not very sure. But there is a theory going on that waste management, if it is not been properly handled, that could be a social determinant which may trigger tuberculosis.
Yes, what happened, sir? This bacteria can survive with this small dust in the air only. How this bacteria will go into the lungs when we breathe? It will not be survive. Nah, it will be survive with the small dust. So if they are spitting here and there, and it's available in the waste management and all, definitely. What is that? Again, airborne infection control measures. Still, there is a effort taken long back. Airborne infection control measures, but if still we are not able to succeed it. I agree with you. This is the one factor needs to be studied.
Anyway, today is World Doctors Day and today is Zero Waste Day. So right time we have been talking about a killer disease called tuberculosis. Thank you, both of you, Dr. Muniyandi and Dr. Karikalan. Wonderful session we had. Now, Dr. Gopi sir, you can
This through.
question answers.
Yeah. Participants, you may please unmute and ask your questions, please. Yeah, Sanjay, please go on.
Yeah. Sir, very useful information. I just wanted to ask, as you said, awareness is lacking. So one question is, like when you said a TB patient spreads around 10 to 15 people, so do you think that masks should be used? And that is number one, sir. And secondly, the when you said that 40% are asymptomatic, I mean, they don't have any symptoms. And extra pulmonary. So the medical staff, basically doctors, nurses, and the other personnel, do they get also get affected with TB? Any study has been done? And especially in an air-conditioned environment also, you are saying it has been seen. So hospitals are air-conditioned, doctors place the air-conditioned. So can you throw some light on that?
Yes, sir. So first one, like you told, masking is very much required. Somehow at least when the patient is infected, the infected family members, the person's family members, they should be wearing mask. Household transmission is very high. TB it spreads among the close contacts. When you spend more time within a closed space in your household or with your friends, it is not spreading as quickly as COVID, but consistent transmission happens when you are very close. So masking and hand hygiene is very important. As well as you have to dispose the sputum and whatever it is in a very careful way. This should be followed at least for the first 2 months of treatment. First 2 months, whenever you start taking the ATT treatment, within 15-20 days, your lungs will be sterilized. Then infection spreading, it is very less. So at least for that time, the patient as well as the household members have to remain mask. Mask is a universal thing. If you can use the mask in the public places and everywhere, surely the infection will reduce. Masking, there is no question. It is the most cost effective and very useful intervention. And extra pulmonary, like I told, there are two types. One, the extra pulmonary is something which is occurring outside the lungs. That is called a extra pulmonary. But in the asymptomatic TB, this 40%, which I told, even within the pulmonary TB patients who are having lung TB, even among them, 40% are having no symptoms. That is very problematic. TB is getting highly adapted. Previously, we had that classic symptoms of cough and fever.
Hello?
Cough and fever and yes, sir. But now 40% of TB cases in the lungs. The lungs, I am saying, it can be diagnosed only if you take a X-ray. Only with X-ray we are able to. It is becoming very manipulative. So that is the reason many people are coming only after their lungs are completely worn out and completely TB eats up their lungs. Many people are coming after 3 or 4 months of infection, and it is very problematic to save them. And now like you told, these AC rooms and closed setups and healthcare workers are highly at risk of TB, especially when the healthcare workers unless they are having proper nutrition and masking and everything, they are at high risk. There are many studies which have shown that they are having an increased risk of infection. Even we at NIRT, we are having the risk of infection. We have a lot of lab and patients are coming. So in our office, the main thing, whenever comes inside the office, the first thing we say is to go to the canteen and take the food. So we have our canteen from 7 o'clock. So that is the first prevention. We will not allow our staffs to work without having morning breakfast. And nutrition is the very important thing. Healthcare workers are very high risk. Even so, one thing which I wanted to share is recently South Chennai, when you take Chennai, every year we are having some 15,000 cases in Chennai. And most of the cases happen in north and central Chennai, where you have very dense and vulnerable population are there. But recently, in last 2-3 years before, they said that Velachery corridor is having an increased incidence of TB. So TB is no more restricted to these areas where poverty is there. And extrapulmonary TB, it is affecting everyone. And extrapulmonary TB, more women and adolescent children are affected. And transmission, it is not through lung route. It happens, it gets activated somewhere. Extrapulmonary is common for everyone, and it is becoming a very high problem. Now, the social determinants still are in place, but, even people from the high socioeconomic status who are confined to their AC rooms, they are also at risk of TB. We are seeing reports are happening, sir. So prevention is the best way. So awareness and literacy about the symptoms and proper nutrition and staying away from your, risk behaviors and sedentary life, your lifestyle. All these things are very important. That is it, sir.
Sir, one more thing. This diabetes and HIV patients, more than them, it is this alcoholism and malnutrition, which is affecting TB.
Yes, sir. Right now, the HIV we have controlled a lot. HIV was a main determinant. In countries like Africa, still HIV is the main driver of TB. Here, we have controlled HIV a lot. Diabetes is emerging. Diabetes is emerging as a very important comorbidity, but Typically, when you take India, when the alcoholism plays a very important, almost 10% of the cases you can attribute to alcohol related things. It plays a very important role. Undernutrition is the top one. Next, I would say, alcohol, then comes the comorbidities.
So in like in China model, like China is more population
Yeah.
and we are less, but still we have more
Yeah.
TB.
Yeah.
So any model study is there? Any like what they do?
So, yes, sir. Actually, we have 25%. I think China has some 11% of the global TB cases. China's data on this, sir, we don't have much, sources and, models. But one thing on they have very heavily invested on, TB has a direct correlation with the socioeconomic development. So even we are improving, not on par with China, but we are also improving. They have even before ATT was discovered, Western countries were able to control TB. Even before antibiotics. Reason one they have changed the way they live in their urban centers. Slums were cleared out, sanitation was improved, free nutrition was given. All these things played a very big role in the elimination of TB in Western countries. In addition to ATT, even before our ATT and rest other things started, when they after World War they controlled most of the TB. That is purely due to that socioeconomic level interventions, as well as the standard of the income level and the standard of the patient. Most of them are affected from the poor socioeconomic status basically. So it is a high, we are giving free medication, free diagnosis for everyone, irrespective of whether you are from any. But still, if you are not able to control, then the problem is not with the TB program. It is in the society. 100% free. Everything is free under TB program. But you keep on getting new patients, and then they keep on, 10% of them fail or die. Means there is some problem with the society, and stigma has a very important role in India, sir. That disclosure doesn't happen, hesitancy and discrimination. I know, because unless you don't feel stigmatized about yourself, you will not be taking the medication properly. You will not get the family support. I think these are some cultural things which we have to say. With regard to China, we have kind of less data to say. There are other countries which are very nicely. For example, they talk about Cuba. Cuba is still a pure country, and we had one. There was a union. There is a big NGO called as Union. His president was giving an example. Cuba is an example where even though a country is poor, they were able to eliminate DB due to social interventions. And there are a lot of social models. For example, South American countries, few have adopted very good, DPT models they have enacted. Basically, it is social interventions which will result in elimination of TB, and our standard of life and economic output also is correlated to TB.
Actually, sir, as per that table which you shown,
Yeah.
it is actually alcoholism that is more alcohol and less food.
Yeah.
So that social determinant is very clear. And
Yeah.
alcoholism, like I am seeing more outlets being opened now.
Yeah.
Because it generates revenues for the state.
Yeah.
So it's a fight anyway. And the CSR can be actually more focused for awareness.
Yeah.
If there is a if that has to be tapped for
Yeah.
spreading awareness,
Yeah.
I think that's all. Otherwise, sir, very useful information to all of us. Thank you,
Yeah.
sir.
Thank you. Thank you.
Sir, is there a diagnostic like you are testing for sugar and cholesterol? Is there a diagnostic thing a normal person can go and get it done, or only
Yes,
when
sir.
symptoms?
So,
Only when
sir,
symptoms
actually, we
you are
have two type of diagnoses, sir. One when you have active TB, 50% of our population is infected by TB bacteria. That is called as latent TB. For example, if you test in your skin, there was a test called as TST. Like in BCG, you have that scare. Whether there is something called as TST testing.
Manto.
Mantox. Yeah. Okay. Now it has been replaced with a kit called a CyTB kit. Within a few minutes, you will be able to see whether you have TB bacteria in our body. It will be a latent TB. It is not an active TB. So that thing,
Why
CyTB,
nobody is
it has
recommending?
been validated by our Muniyandi sir, has done a cost effectiveness study of that. CyTB is coming up where you can test for latent infection. If you have active TB, for example, if you have a symptom of TB, but if there are two tests. One is sputum test, what we say. We collect your sputum and then we put it under microscopy to see that. X-ray we do, and then we have this gene experts are coming up, genomics based test. So they give result within 48 hours. They will be 24 hours. They will be able to say whether you have a mycobacterium in your sputum or not, whether it is drug resistant or not. So previously, it used to take a lot of time, but within 24 hours, this gene expert will clearly say whether your sputum has a mycobacterium or not. And right now, we have a lot of digital X-rays or their handled X-rays. So artificial intelligence based X-rays are coming up. So it is a matter of 24 to 48 hours to diagnose TB. Diagnosis has really improved a lot.
So, but there is no need for a normal person to go and subject to test. I mean,
Yeah, so a problem.
like a
Sir,
yearly physical check.
yeah, that is enough. But for the vulnerable groups, for example, in TV program, we are saying that we have to go to the community and screen many people who are, for example, if a person is having malnutrition, if he is underweight, if he is a coal miner, if he is working, if he is living in a slum, if somebody in his family is having TB, these are all called as vulnerable population, which Muniyandi sir has told. So those people only we can screen, annually or biannually. They are at high risk of TB. But there is no need. Everyone has to be subjected to TB. We can do that side TB, latent TB. Only we can check it out in our body. That is quite less invasive. It takes few minutes. That will give an assurance that you don't even have a latent TB in your body.
This is what,
Sir, sorry, what happened, sir? So far, the diagnostic facilities are based on sputum. How we can get sputum? Once the symptom developed, then all the diagnostic tools, smear microscopy, gene expert, TrueNet, all based on sputum. So now only alternative is X-ray. And again, we can't expose everybody for the X-ray. So far our experience, sputum is a major symptom for tuberculosis, though, so it's easy. Now again, the science is changing now. Asymptomatic patients are getting more now. So now this X-ray only available, but there are researches going on, blood-based, urine-based, stool-based tests they are trying.
something
If
like
it is available,
something like cancer marker, like you.
then again marker also they are trying, but I don't know how it will be useful. What they are saying, the public health concern, if they have a symptom, then they will spread the others. If no symptomatic, they won't spread others. But again, you are right. When they do now all the government sector annual, they have to do screen and they have to report to the government whether they are medically fit. But in that they are taking X-ray. I think that will give whether they have a TB or not. But in the whole population, it's not possible. Again, government is already recommended and already it is doing it. All household contacts of TB patients to be screened. Compulsory, they will be screened. All HIV patients to be screened. And another one, that geriatric, any operation or anything, it's like a key population or vulnerable population, high risk group population, compulsory they have to be screening. They call it as an active case finding, like actively they have to screen. Then again, the community also they are trying. They are trying in the HV, then they are visiting the community. They can identify the vulnerable. They have to screen for these things. But again, they are trying to like pregnancy test, rapid diagnostic test for other things, hepatitis B and C. These companies, they are trying to develop some tool which we can just take fingerprint blood, then they can diagnose TB. Their research is going on. They will try it. And again, now new technology, this artificial intelligence coming into the picture. So cough sound, they are trying to develop a diagnostic tool for diagnosis based on cough sound and other risk factors. How this COVID they tried, Nangsa, you have these symptoms, then you have a suspected for TB. Something then that these are all new developments they are going on.
no, actually, 30 years ago, when I did my master's in international health in Denmark, what my professor said, now it is coming reality. For example, now after globalization, now especially country like India, where the migration is happening everywhere. A person from say Bihar coming to Chennai as a cab driver, we don't know whether he is affected, and we think we are traveling in a taxi safely, but in a closed environment, in a taxi having a AC, and you are traveling, and one sneeze can spread the disease, isn't it? That is possible, right?
Yes, sir. Yes, sir. Yes, sir. I think Dr. Karikalan sir is doing study on this drivers and conductors. Because if they are risk, they are AC cars, there's a long travel. They are staying 2-3 hours, and the normal driver conductor they are staying in the. You are saying that they are polluted environmentally. They are risk. Then the exposure. We don't know who TB patients are traveling in the car and bus. I think Dr. Karikalan sir is doing that study. Then we will wait what is the result.
Even that, the last community advisory board, we discussed about it, especially the policemen, the traffic police, they are exposed to the dust and they are
Pollution.
vulnerable, yeah. And the auto drivers and informal sector, as you rightly said, the poverty being a major determinant, screening has to be done at least once in a year.
But for pollution, this mask, sir, mask is good. But we can't ask everybody to wear mask. Patient can wear mask so that this can be prevented. We can't ask everybody to wear mask like COVID.
That's right.
Patient who is infecting to others. But we don't know how much protective for these masks. They have to go for N90, which is a very more filter mask.
Exactly.
That mask. Again, the TB patient now already they have a problem. Breathlessness is a one major problem, a major symptom for tuberculosis.
Yeah.
If they wear mask, then we don't know how they are comfort with that.
There was a question, sir. Someone was asking, Mr. Narayana asking whether it is a hereditary. The TB is a hereditary. There was a question there in the chat box.
No, it's not hereditary at all. It's like a bacteria. When everybody, those who breathe, they are risk. Bacteria will go inside the body. It will stay sometime. It never developed lifetime, but sometime when we develop the disease, sir, then we need to treat. Not hereditary, but household contacts are very high risk. They are more exposed. Somebody TB patient in the house, they are sneezing or coughing, the bacteria will come out, the household contacts will breathe, then they are high risk for tuberculosis. Now they are saying the household contacts to be treated with the preventive therapy. It's not hereditary, but it's more risk in the household if anybody have a TB. Now they are saying children in the TB patient's house, children is there, they have to give chemoprophylaxis. The children are more vulnerable and the elderly population.
Thank you, sir. Thank you.
Hey, good morning, everyone. I'm Muthu Kumar. I need to go, so Gobi, can I just make some quick
please go on.
observations on go?
Yeah, please.
Oh, fantastic discussion, sir. Really good. I just have two observations. Everything what you said was it was right actually, but the challenge has been seen. If you do the WHO's recent statistics of 2021 and 22 for the highest causes of death across the world, tuberculosis is coming only at 1.4 million deaths actually, whereas cancer and heart disease is much higher. I heard that 13.2% of the 2020 there were 68 million deaths across the world, and heart disease contributed 13.2%, cancer about 4%, but tuberculosis only about 1.4% and 1.4 billion deaths actually. So the problem is that, and as you correctly pointed out, sir, it is tuberculosis is a poor people disease, not from rich people disease. It is morely concentrating on Africa and India and Bangladesh and Pakistan, not compared to, you can't see that in UK or US, Australia or the Middle East. And the challenge for us, how to educate the population. The mainly problem is this is a very interesting topic and very important topic. The challenge for us is that how to make people aware when the poor people, when it is a poverty-driven disease, people living, and when the problem for them is the survival against disease, sir. That is the problem, irrespective of what we discuss politically, judicially, or religiously, anything, whatever we discuss. For the poor people, we had a lot of discussions. One of the time there was a big study by one of the major corporations. One of the challenge with the poor people is when it comes to survival, survival is critical or my disease is critical. Although they know that it's a risk for them, they may die at some point of time. The family can go without the breadwinner. but still for them survival becomes an issue. So they actually do not care for it. So we can give a lot of help, we give donations, we can give gifts, and we can take care of some TB patients. But the biggest challenge for all of us is that how to create that awareness. Because today, look at it, there was an article, people go to theaters now. And the theaters are, no one knows who is coming next to you. The guy sitting next to you in a theater can be a tuberculosis patient. And people get tuberculosis just by sitting in a theater. And no one knows exactly how to control that. Similarly, you go to temple, Kumbh Mela happened now. Yes, religious. I agree. Fantastic. No problem at all. But millions of people actually were together. And one time government says you have to reduce the people crowding for avoiding tuberculosis. And they're allowing 10 million people to go to Kumbh Mela to take bath in a small area where tuberculosis can spread like anything, any other contagious disease. So this is a paradoxical issues are in the country. I don't know how we are going to resolve it, but you're right about it. It's going to keep growing actually. And because of this problem, a lot of rich people also getting tuberculosis today. It's not uncommon because it spreads everywhere. So that's one challenge, sir. So I would awareness apps and everything is good, but one of the major things actually we have to do to bring awareness is to make people have a better survival capabilities and capacities. That's one important point, sir. That's what I want. Second thing on the GDP, and so this very important aspect of GDP is it's all for me it's all a lie. Because see what happened, how the GDP is calculated, sir. GDP is calculated on the transaction of any kind of expenditures and money either by the government or by the individual people, either by free movements or anything. Any kind of transaction of cash is included in the GDP of a country. When the GDP is growing at 1.7 or 1.8 trillion dollars, the amount of billions of dollars spent on TB treatment is also included in the GDP. So a government cannot say that I have grown 1.8 trillion dollars of GDP, but I'm losing 28 billion dollars in TB, which is it's a paradoxical issue. It's ironical, paradoxical issue. So that is wrong. Everybody is taking that, but question is, are they deducting the money spent on tuberculosis from the GDP? No, sir. They don't do that. So when a lot of economics, even if you look at some place like Raghuram Rajan from the ex-RBI government is talking about, and he mentions that point that our GDP is not calculated correctly. It is proposed to people wrongly. So public support systems, money spent on public support system should be deducted from GDP, but it's included. So these are the two major points, sir, and I'm happy to help in whichever way. I am a writer, and I can help in any way to create contents and write-ups, literature, books, anything to support your case, sir. I'm there, and my numbers are with Mr. Gopi. I'm available anytime you can contact me. Thank you, sir.
Thank you, sir. Thank you for that wonderful insight, sir. We will be discussing, sir, a lot. I know we need such experience and inputs. I think Muniyandi sir will also agree. He is a senior economist, so this will be something which we will be interested to talk with you, sir. Thank you.
Thank you,
Yeah,
sir.
yes,
Thank you very
sir.
much. Thank you,
Thank you.
Gopi, sir.
Thanks for your very valid comments. What happened so far, you are right. It's a poor man disease. So many developed countries not invested to innovate many things. Again, very recently, maybe last one decade, government has taken some effort and they have invested and so many innovations are come out. Previously, it's like poor countries, not much innovations to innovate. Now, there are regiments, shorter regiments, 6 months regiments, new diagnostic tools, everything is come up. And again, government of India, it's again based on this HIV. HIV time, people said, we are dying because of no money. So now the situation is different. Government that indigenous and again in country innovations are more come up many. Then again, other one, it's no doubt about this is contributing to the it's affecting the economic development of the country. You are right, but not much studies done, and we have estimated it is affecting like economy of individual, economy of the family, economy of the country. We have already proved. Then it's got like its TB control program is not only the health program, it's again a developmental program. In 2000 itself, the WHO and everybody's agreed. Another still we are not able to provide enough evidence. Government what is the contribution TB program investment in the contribution to the program is in further development. So this is a good thing, sir. Again, we will discuss that. I'm so happy to
Thank you, sir.
further
Thank you
discuss.
very much. Thank you, sir. Thank you very much. Bye.
Thank you, sir. Sir, one small question regarding this mask used in public places. Like a person who uses mask always in public places, whether it is air-conditioned taxi, theater, trains, or whatever, and a person who does not use it, is there a immunity, like if you use mask, the immunity drops? Body's immunity?
No, not like that. See,
Mhm.
since the infectious diseases, it will come out from this mouth, like sneeze
No,
and cough.
this is,
That
no,
can
no.
be.
Sir, what I'm asking is for a normal person, for a normal, let's say somebody who's 50 or 60 years old, he's healthy and all that fine, but when you go to public places, he wants to use a mask. And compared to a person who does not use it for the same age. So whether use of mask brings down the immunity of a person or not, that's what I want to ask you. That's all. I mean, a healthy person, not a affected person.
It's a good for the prevention from that airborne diseases, healthy individuals. It's a good. That's what I can say.
Nothing about, nutrition has no role, sir. Nutrition has nothing to do with mask. It is just for, preventing the droplets from entering into our mouth. Nothing. Otherwise, you will be breathing the same air, everything, except it filter out those, droplet nuclei. That is it. Nothing.
Okay, sir. Thank you, sir.
Shamla, Ramkumar sir, any questions? Ramkumar sir, Mangalam madam.
It's been a wonderful talk, very enlightening by those two stalwarts in their fields. I think it was wonderful. I enjoyed the program very much. Thanks, Gopi, for arranging such wonderful programs. Mr. Muniyandi and Karikalan gave a wonderful exposition of what tuberculosis is all about. I thought tuberculosis is only for those people who are there. I think tuberculosis can affect so many people. And as he said, I think it's a poor man's disease. So we are a little comfortable there, but that doesn't prevent us from being a little bit more careful. I think we need to wear masks. I find that doctors themselves are not wearing masks inside hospitals. And preventing children from going into hospitals, I think it's a very important aspect. And in flight, when we travel, people don't wear masks. And there was somebody, when I came from Ayodhya about 3-4 days ago, there was a guy continuously sneezing and I didn't have a mask. I was so helpless. And when I asked the hostess, she also didn't have a mask to give me one. So I think this wearing mask, I think is a very important factor for those people who actually live on main roads. And I think it amounts to actually even, it's kind of a passive smoking guy living in the main road or working on the main road. I think it's equivalent to consuming 1 cigarette or 2 cigarettes a day. Those people who live on the main roads. And this one carries the spit of people also, along with the dust. I think it goes into people's nostrils and then people do get affected that way also. It's a passive kind of a thing also. And actively, I think people living in slums and other people do get affected. Malnutrition and this one, BMI is less than 20. Those malnutrition people also get affected. It's some very enlightening talk. I think I got to learn a lot about this talk. Thank you very much, Mr. Muniyandi, and thank you very much, Dr. Karikalan. And thank you very much, Gopi, and all the other organizers for organizing such a wonderful program. Thank you very much, Gopi.
Thank you,
Thank
sir.
you, sir. Dr. Shamla? Anyone else has a question? Suresh, sir, you want to wind up? Sir?
Like all others have said, I think it's an excellent program. And we, of course, know about, the government's efforts that have been ongoing for the prevention of tuberculosis and also for its elimination, one can say. It is a public health challenge, and I think today's webinar highlighted not only what are the kind of risk factors that are there, and what are the kind of preventive measures which have been suggested, but also how each of us individually can also take care of ourselves and help in this particular program and make sure that India becomes TB free. Thank you. Thank you so much to both the speakers and all the discussants. I think it was a wonderful session. Thank you so much.
Thank you, ma'am.
So in continuation of the last week's session, Sundarajan sir is there. We can add a few points on climate change and the health issues. It'll be nice to hear.
Sundaraj is not there, sir.
Sundaraj sir is there.
No, sir. No, that's a different. This is a different Sundaraj, sir.
Oh, I see. Okay. Anyway, so actually, climate change, sorry, ICMR, NIRT has got, sir, Karikalan, sir.
Yes, sir.
Sir, can you brief one minute about that mobile vans you mean ICMR has got, which we conducted in places. So need not patients to come. We can reach the patients, and we can do the thing. So if anybody is interested, so they can organize a health camp. So can you brief on that, the mobile?
Yes, sir. So one thing on the program, like you told, early detection of TB. Right now we are having a lot of asymptomatic, 40% without symptoms. So program we conduct along with program, we conduct a lot of screening programs in the community for TB. So we have our handheld X-ray and mobile X-ray vans. So we reach to vulnerable populations where they are living, and then we do active screening for symptoms, as well as we take X-ray for all of them. So in that way, we detect a lot of TB. So we do it along with awareness. So we bundle our program with the TB awareness, nutritional counseling, as well as we do this screening program. So in a single place, we will be meeting some 100 or 150 people. It will be for half a day or something. So we will, we have our own X-ray vans and mobile vans, and our team is there. So if there is any particular community where there you feel there is lot of chances for infection or vulnerable people are there in Chennai or Tiruvallur, somewhere we will be ready to help out. Even if there is another district, we will try to contact someone. If it is in Chennai, we will be ready to do that. We routinely do that every month. We do that kind of active case finding. And with regard to awareness, we are ready for any time. We have a very good team of awareness is something which we want to keep on doing in a reinforced way. So we have a big team of social workers and our interns and public health people. So we have a wonderful team. We keep on every month, at least we will have some 2 or 3 awareness sessions, whether it is in offices or in community settings or schools or colleges. We have different type of awareness material, not only, we have folk-based awareness things. We have booklets, we have skits, we have dramas, singers. We have a good variety. Awareness we believe, being from social behavioral department, we think that awareness and behavior change are the cornerstone of TB elimination. So we will be happy to engage if anyone likes to have an awareness meeting in any of your places, as well as active case finding. Yeah.
So in addition, we have a forum called Community Advisory Board, in which I am the vice chair, and we are looking for channels of financial support for the nutrition support for the patients. So from the AABN forum, if anyone has got the linkages for CSR support directly or through some channel or any other support that way, so you can come forward and you can share your inputs, so that we'll definitely acknowledge that in the national forum.
Yeah,
and that will be a great support.
And we have a very good, TB survivor network. We have a, they are, most affected people, and then we have some 2,500 TB survivors in Tamil Nadu under one network. So if there is any way you can provide some kind of training for those women, especially it is made of more women survivors, any kind of skill building or training or any kind of opportunity for those survivors, economic empowerment is also needed for them. That will be a huge help. It doesn't need to be monetary. Any kind of opportunity to engage them to improve their skill or job seeking capability, that will be welcome. Yeah.
Yes, we can wind up, sir. Thank you.
Hi, sir. Anyone else has a question? One last question, if somebody has. Kavita.
can you tell us drug resistant TB? What is that?
Gopi sir, I guess you call my name.
Yeah.
Okay.
You have
Yeah, I don't have a question, but I would like to appreciate. I thoroughly enjoyed this session for the knowledge sharing. Very nice and very briefly, and some points have been. I mean, it's kind of they made us to think. It kind of they created an awareness what we should do and what we should not. And I actually logged in little late. My apologies for that. And I thoroughly enjoyed the session. And thank you very much for bringing such good and nice, knowledgeable speakers and giving us this knowledge. Thank you, speakers. Thanks a lot.
Thank you.
Thank you.
So can you just go about multi-drug resistant TB? I mean, what is that different from?
So, sir, actually, most of the cases, till some 15-20 years before, if a person gets TB, if you can provide a ATT anti-tuberculosis treatment within 6 months, there are some 4 drugs which is used for TB, 4 antibiotics which is given for TB, you will be completely cured. But over a time, it is not only with TB, there is a problem of this antibiotic misuse or non-adherence. You don't complete the treatment properly. So you take a TB treatment for first 1 month, and then if you see the improvement in your body weight, your cough reduces, then people stop taking treatment. So now the bacterium become resistant. Next time, again, he will get a reinfection. And then if you start taking the same antibiotic, it will not be working. So that is called as drug resistance. So your medicines, your bacterium becomes resistant to the antibiotics. So in this way, out of the 4 drugs, we have developed almost right now, 30 to 40% of the patients are having monoresistant. Any one of the TB drug doesn't work for them. And there are people, none of the drugs work. You have to go for new drugs. That is called as multi-drug resistant. So it is highly fatalistic. Before some 2 or 3 years, the multi-drug resistance was so complex to treat. You have to treat the patient for 24 months. Standard treatment is for 6 months, but you have to treat these patients for 24 months, and the fatality rate is almost 60 to 70%. Almost 2/3 of the patients will die. They will not respond. And the worst thing is, these patients, when they cough, they will spread the resistant infection to other people also. They become multi-drug resistant, So now we have developed some good regimen. Our institute has played. There are some new drugs are coming. There is a wonder drug called as bedaquiline. We are trying to treat that MDR patient with this bedaquiline. We are able to treat them within 9 months, 9 to 11 months. But still, this bedaquiline is becoming resistant again. So TB bacterium is highly adaptable. Whatever new drugs you bring in, so it keeps on getting adapted to that. So drug resistance is going to be a big problem, not only for TB, for all the infectious disease. We have overused or misused all the antibiotics. There the behavior part is important. So we think that antibiotics will be working forever. That is not happening. And TB is a good example. We have misused the antibiotics. On one hand, even for mild cough and everything, we start using antibiotics. Patient doesn't take the antibiotic properly. Doctors doesn't educate the patient that they have to complete the treatment 6 months properly. So all these things have led to this drug resistance. So we are going in a place where the normal bacteria is slowly vanishing, and every bacterium is becoming a drug resistant bacterium. So this is a kind of a new pandemic, drug resistant pandemic we are facing. So behavior change is very important, and medication adherence is very important to combat this. Yeah.
Thank you very much, Dr. Muniyandi. Thank you very much, Dr. Karikalan.
Thank you, sir.
Thank you very much.
Thank you, sir. Thank you for this opportunity. And again, any help from us, we are very happy to do that.
Sure, sir. We look forward to that, sir.
Thank you, Dr. Muniyandi, Dr. Karikalan. Thank you so much.
Thank you, sir.
Thank you. It's a pleasure for meeting all these people. Thank you. Thank you, sir, given this opportunity.
Thank you, sir. Thank you.